infertility training, Delhi Gynecologist Forum. This is the 30th batch, and COVID has brought things very easy for you. You should ask Dr. Sangeeta, Dr. Sheila, who have had come here, leaving all their practice for 7 days, and they were here. And now they have come for a second week, and it is good that they have thought to get it revised, and we are giving them opportunity for their revision. So the revision will be there, and Sushma and Dr. Kajal. My request is to you is that आप एक हफ्ते का तो कर ही रहे, and if you make up your mind, you should continue with the second week. ये किसकी आवाज किसमें है? Whose आवाज कौन सी है? मालती? मालती? प्लीज सब आप लोग को म्यूट कर लीजिए. डॉक्टर सुषमा म्यूट कर लीजिए. डॉक्टर सुषमा म्यूट कर लीजिए अपने आप को. That's right. So disturbance नहीं आएगी, then you will be able to hear me much better. Done? So what I will suggest to you is if you're motivated, you should do the second week right away, because we feel that if you do a training and go, that will be great. That will be great with you. And what I want is that for first 1 week training, we are doing everything. We can do a live. You can see it. But if you can come on Saturday, that will be great. So Dr. Sushma and Dr. Kajal, will you be able to come to do your hands-on, or you will be coming later? Sushma?
Later, ma'am.
Later, okay. So you will see everything live, you don't have to get worried about it. But if you can come down and, do something live, that will be great. And the same is with madam who are doing the second week. We definitely want you to be with us at least for 2-3 days. So then, the perception of the whole thing becomes really great. And from this place, Rajasthan, it is not difficult. And from the other girl is from Calcutta. She has to find it out whether she wishes to come, because आने में अच्छी बात है, और नहीं होगा तो then we will work out things. So today I'm going to give you an overview, and then I will talk about the examination. ठीक है? नहीं आया स्क्रीन. You are presenting. ठीक है. आगे. Now, I wish to tell you that, in 1978, the first IVF baby was born. After that, long way we have come. Now, what are the developments which have taken place in the last 40 years, since the time the first baby came? We find that art of controlled ovarian hyperstimulation was made easy. The concept of luteal phase support also came, and then improved cultural media came. Then ICSI followed, and now in IVF you can find assisted hatching, and various things have improved a lot. So I will go slowly on the line, but I will definitely give you an overview. What you are going to see as an infertility expert. All of you are entering to phase, then after training and after grasping the subject, you'll be able to say that we have picked up quite a bit, and now we can I justify that in front of my name, it is written infertility expert also. Here I wish to tell you that only postgraduates, DGO and MD, can write on their pad papers, they can put up in their board in the clinic that they are infertility experts. Only postgraduates can do it. We also know that many MBBS doctors are also who've taken a training, they can be very good. But they cannot write postgraduate. If they are not postgraduate, they cannot write on their paper they are infertility expert, or they cannot put up in the board or in front of the nursing home that they are infertility expert. For IVF, we all get registration done. But now the directive is that people who are practicing IUI also have to apply to the PCPNDT office for registration. What are the new trends? As far as this country is concerned, we get a mix. India has a mixed population. एक तरफ कुछ लोगों की जल्दी शादी हो जाती है, और एक दूसरी तरफ है कि now because people have started making career, so the girls are getting married late, and then they because they get married late, they still in because they want to improve their career. By the time they realize they want to have a child, biological clock has really moved ahead, and they require ART help. And this is good that as far as our country is concerned, we are not far behind as far as the ART things are concerned. Now, in today's time, roughly 2 lakh cycles are being done, and 55 IVF cycles are done in metros, and the top 8 metros, and the rest 45 are done in second and the third tier cities. And the prediction was that by the end of 2020, this IVF will touch 2.6 lakhs, and I'm sure it must have done it. But setback has been there because of this coronavirus, so expected 2.6 may not be there, but at least 2 lakhs is the rough estimate that these number of cases are being done in India. Infertility bothers 15% of people, and it is a question of life and death for Indian patients because to have one child is prestige point. Ladies को बांझ कहेंगे और हर तरह की ताने देंगे, but even men folk को भी परेशान करते हैं. Most doctors who are MBBS, for MD doctors and DGO doctors, they read infertility as only one subject. The in-depth knowledge of infertility they do not have, and that is why their approach is lopsided. Most doctors, because a lack of training, they wait and watch approach karate hain, and that makes the patient very frustrated, and they drop out in the treatment after wasting a lot of money. So the common mistakes which what not to be done are the couple should be seen together. Now the males are pretty receptive because now they have come to know that male contributes 50% to the infertility. And I still find that even postgraduates have not got the semen analysis done even before the IUI. They come to know for the first time that the patient is having azoospermia when they ask for a specimen in IUI. Investigation are done in a piecemeal fashion, not in a strategic way, and that is why they get frustrated, and this is all because of lack of training. Then when the patients get frustrated, they change the doctors, and the other new doctor wishes to repeat all the tests, again wasting a lot of time and money of the patient. So much so that repeated endometrial biopsy, even a laparoscopy unnecessarily are being done. A small fibroid, and because of the lack of knowledge, they say a myomectomy is required. And for cyst, where you think, she could simply get all right with the simple OCP. Ovarian cystectomy is offered left and right for a small cyst as well. So this is what is the problem, because we are not well trained. This is, I was talking about myomectomy. We'll talk in detail about it. Only some mucous myoma requires attention. The rest of the myomas do not cause infertility. We should also become very careful about it, that बहुत सारी unnecessary investigation we should not order. One of such example is torch test. And after abortion, sometime you will get a battery of cells like TNF alpha, NK cells and other things for which we do not know what is the interpretation like. जिसकी भी interpretation डॉक्टर को नहीं आती, उन टेस्ट को नहीं करना चाहिए, क्योंकि they drain away the money and without any benefit for the patient. Now, the harm done by the doctors not trained in infertility, even after MDDGO is, that is the Bain's con, that they lose trust in the doctors. And the temptation to try many empirical things are there because they do not know what is right. So, koi bhi cheez bata dega, to it is almost like quacks, they start practicing it. And I feel this self-styled gynecologist practice infertility, it is bad. Now, what is the role of doctors who are not gynecologists? Unka kaam ye hai, refer to the trained infertility experts. A woman is not pregnant within a year of marriage, provided they are staying together and not using contraceptive. Best time for conception is between 20 to 25 years for females. Remember, decrease ovarian reserve in Indian women is seen 6 to 7 years earlier than our Western counterpart. I repeat again, हमारे जो ovarian reserve की कमी Western counterpart में 35-36 years में होती है, हमारे यहाँ ये 6-7 साल पहले हो जाती है. तो sometimes it is not surprising that age of 30-29 patients AMH is very low, less than 1. Now, what gynecologists should do, and all of you are lucky gynecologists are, get trained well in infertility. The couple must be seen together and treated as a unit. First, find out the reason for the infertility. The workup protocol must be explained to the patient and should be completed within 2 months maximum. In fact, it can be done in a month's time. And we all know it can be done in a month's time. That's right. Now, here you can see how the pregnancy is brought about. When the egg unites with the sperm, the baby is formed. And this is done in this third part of the fallopian tube. The egg, at the time of ovulation, this fimbria encircle around the ovary like a cup. And then egg is released, and this egg is fertilized with the sperms, which has come all the way via the uterine cavity, the fallopian tube, in third part of fallopian. The fertilization takes place here. And then zygote is formed. Then on day 2, 2 cells are formed. On day 3, 4 cells are formed. And day 4, morula is formed. And by the time it reaches the endometrial cavity, it is day 7 and it is blastocyst. And then blastocyst, and the mother has a dialogue. The blastocyst asks, please allow me the entry. So sometimes it allows the entry, and sometimes it does not open the gate of the endometrium for them. So that particular pregnancy is discarded. Is it clear to everybody? Is it clear to everybody? Yes. बीच-बीच में हाँ हाँ बोल दिया करिए. Now, cost-effective strategy of a couple is 4 things are needed to make a baby. एक बढ़िया क्वालिटी का अंडा होना चाहिए, बढ़िया क्वालिटी का sperms होना चाहिए. Uterine cavity should be absolutely great, without tuberculosis, without any malformations, and the tube should be patent and functional. Patent and functional. Now, cost-effective strategy क्या होगी? Semen analysis should be done during the time when the lady is having periods, that is during her menstrual period. Blood tests which are required in 2020. Day 3 में एक इसका AMH करा लो, एक इसका TSH करा लो. Other tests are really not needed. Rule out genital tuberculosis. It should be must, because in 40% of patients in the northern India, we find tuberculosis is the underlying cause. Tube testing has to be done, which can be done by sonosalpingography, it can be done by histosalpingography, and at the same time, we do an office biopsy to rule out tuberculosis. tuberculosis it's a ruling out is must. And this is done, and then we ultrasound monitors for ovulation monitoring whether she's ovulated in that particular cycle or not, and then we confirm it by day 21 serum progesterone, and that completes the cycle. A cost-effective testing strategy में आज की तारीख में laparoscopy is not needed to complete the workup, as laparoscopy is invariably okay when the transvaginal sonography and the hysterosalpingography is normal. अगर ये दो टेस्ट बिल्कुल नॉर्मल है तो आपको लेप्रोस्कोपी की जरूरत नहीं है. Even in endometriosis now, it is said that the surgery is not, laparoscopy is not needed to confirm the diagnosis of minimal endometriosis. Now, caution is, whenever you get one report of azoospermia, or you get a blocked tube, or you get a blocked tube, in that particular cases, this testing should not stop with one problem. In azoospermia, when we'll be going to talk about minimum 3 specimens should be tested, and not only tested, the semen pellet should be examined in IVF center or in infertility center, and if that pellet also does not show sperms, then only you should be able to label that particular patient as azoospermia. Sometimes you find you do a hysterosalpingography in a surroundings and there's a lot of pain. Sometimes there can be spasm is there and you label it as a blocked tube. So in that particular patient, one has to see that probably a repeat test of other kind will be required for the tubes to confirm your things. If you know, if your setting is there for last 5 years, she is not conceived, and you see on a hysterosalpingography blocked tube is okay. But a newly married girl of 25, 26, and if you say it's blocked tube, then I think you have to be doubly sure about it. Now the plan of treatment after the workup, explain the course of the treatment. The treatment should not be an ad hoc single cycle basis. It should be stepwise approach in treating as we do for hypertension and for diabetes. Timed intercourse, 6 cycles for young couples. Unexplained infertility. We advise them if everything is, all tests are normal between husband and wife, then we say that still you can have a timed intercourse of 6 cycles which are duly monitored by ultrasound. Again, there has been a report on by the British Society, NICE guidelines. It says that if patient is staying together with each other and not using contraceptive, patient should be referred for IVF after 2 years. ये वाली बात हिंदुस्तान के डॉक्टरों को थोड़ी अभी समझ नहीं आ रही है. So people feel that they should be given 3 cycles of IUI with superovulation. That is, superovulation is control ovarian hyperstimulation with clomiphene, letrozole, or plus minus gonadotropins. And if she does not conceive with this, then she should go for IVF. Or if she's married for more than 5 years, 5 years or more, she should be referred for IVF. So for Western world, they may be saying for 2 years, but at least Indian gynecologists should definitely say 5 saal mein to kar hi dena hai. As a thumb rule, control ovarian hyperstimulation plus IUI is effective. It works in the first 3-4 cycles. IUI जो काम करेगी control ovarian hyperstimulation के साथ, ये पहली 3-4 cycle में ही काम करेगी. After that, doing repeatedly is a waste of time. And what are we gynecologists do? We keep on doing IUI again and again. We need to tailor-make the treatment according to the patient age, the medical diagnosis of husband and wife, and the budget which they have. Now, critical areas which need to be seen. Tuberculosis in India must be ruled out. Semen analysis, I just now told you, 3 days abstinence, no lubricant should be used. We give them a great guide on how the specimen has to be collected. Now, the bottle which is given for collection of the semen has to be gamma radiated. The ordinary culture bottle which are available are not for semen collection. The semen collection are gamma radiated bottles, and other bottles which are other cultures are different. The jar for urine culture, pus culture is not the same for semen collection. That is one part, and first information you should know that you did not know all this while. Now, in semen analysis, another thing which Government of India very clearly says that no home collection. It should be collected at either in the lab or infertility place, wherever the setup is there. Because from home, when they bring it over, we are not never sure it is their own specimen. It can be of their husband, of their brother, of the father. So please do not. The home samples are not permissible. Better done in infertility or IVF center to avoid the fraud as far as the semen sampling is concerned. Now you can see here the guidelines come almost every 10 years. So there was guidelines in 1990, then 1999, and then 2010. The volume change has from 2 mil, now it has been said that 1.5 mil bhi hoga to chalega. pH was the same. Sperm concentration, pehle wo the 20 million is the cutoff, and now it is said 15 million is the cutoff. The total sperm count, usually if you say that the sample is 2 mil, it means 40 divided by 2 will be 20 million count. And now it has been said instead of 40 million, total sperm count in the specimen given is now it has been said to be 39 million, hardly any difference. Now, motility should be 50%, and out of this, 25% should be progressive. This was old, and now it has been said the progressive motility should be 32%, and that is A and B, and progressive motility should be 32% of the total progressive and a non-progressive motility. Now, I wish just to tell you, 32% is A and B. A is rapid linear progressive motility, जो बहुत तेज चलते हैं, वो जो pregnancy बनाते हैं, और दूसरी जो progressive motility, they are progressing, but the speed is not that fast. And C and D is dead or non-motile, and C is जो कि हुआ making rotatory movement. Morphology earlier was said that in a specimen it should be 30% or more should be the normal forms, and now they have said it should be based strictly on Kruger's criteria. And you'll be surprised to know no lab in the country does Kruger's criteria. So again, we are working in a hypothetical situation. As for the white blood cells were concerned, earlier also it was 1 million, and this now also it is 1 million white cells. As far as the immunobead testing for testing antibodies has been given up in 2010 criteria. Now, you are often make a situation, you get a semen analysis done, husband's wife's testing is all done, and still patient has not become pregnant. Now, the interpretation is that probably there are reactive oxygen species which damage the DNA, and that is why the pregnancy has not taken place. And now it has become mandatory that 1 साल हो गया और आपने semen analysis कराया और देखा कि patient pregnant नहीं हो रहा, तो उसका आपने DNA fragmentation test करना है. We will talk about it in detail. I'm just giving the overview. Then you find that आपने semen analysis कराई, ये तो normal थी, और एक हो सकता है semen analysis कराई and आपको poor parameters पता चले. Oligospermia मतलब काउंट जो है आज की तारीख में 2010 के क्राइटेरिया से अगर काउंट 15 मिलियन से कम है. एस्थेनोस्पर्मिया 32% स्पर्म should be A and B progressive motility, उससे कम है. टेरेटोजोस्पर्मिया जो है वो 4% की जो बात करते हैं, 4% तो वैसे ही नहीं हो रहा. अगर पुराना हम 99 का भी जाएंगे तो उससे टेरेटोजोस्पर्मिया के हिसाब से 30% नॉर्मल होने चाहिए, तो उससे भी आपके एबनॉर्मल फॉर्म ज्यादा है. And third category in semen analysis, you come to know that it is a azoospermia. It can be obstructive and non-obstructive. Now, this you'll be taught in detail tomorrow. Testes is the place for production. Vas is the place for maturation of the sperm, and epididymis is a place. The testis is place of production. Epididymis is the place for maturity, and vas is a place for storage. Now, this is the sperm DNA fragmentation test I was talking about. This is a halo test. Halo test is the sperm which is normal shows head, there is a halo all around it. जस्ट लाइक ए बल्ब जल गया, ये नॉर्मल है। और जिसके साथ चारों तरफ बल्ब नहीं आया, बल्ब जैसा नहीं आता, इस तरह के स्पर्म्स विदाउट हेलो रहते हैं, तो हम उसको बोलते हैं ये डीएनए फ्रेगमेंटेड सेल्स हैं। 200 सेल्स काउंट करते हैं और देखते हैं कि क्या परसेंटेज है। ये पैथोलॉजिस्ट के लिए एक वर्ड है कि नाउ स्पर्म फंक्शन टेस्ट हैव बिकम अ ग्रेट स्पेशलिटी एंड दिस इज द टाइम both infertility experts and pathologists should offer this investigation right at the very beginning. Semen analysis tips in interpreting the report, fructose and pH. जब भी पेशेंट का फ्रक्टोज वैक्टोज की कब जरूरत है? जब पेशेंट को एजोस्पर्मिया है। फ्रक्टोज का मतलब है कि ये सीमन का खाना है, स्पर्म्स का खाना है। तो आपका अगर पेशेंट को प्रॉब्लम जो है सेमिनल वेसिकल प्रोड्यूस करती है फ्रक्टोज को, अगर फ्रक्टोज में ऑब्स्ट्रक्टिव एजोस्पर्मिया है तो आपको फ्रक्टोज नहीं होगा, और अगर ऑब्स्ट्रक्टिव एजोस्पर्मिया नहीं है तो उन पेशेंट को फ्रक्टोज होगा। एजोस्पर्मिया के केसेस में टेस्टिकुलर साइज बहुत इंपॉर्टेंट है। नॉर्मल साइज होता है, ऑब्स्ट्रक्टिव एजोस्पर्मिया में थोड़ा सा टेस्टिस का साइज थोड़ा बड़ा हो जाएगा। एग्जामिनेशन से आपको पता चल जाएगा कि इसमें स्पर्म्स भरे हुए, इसमें खाली बस नीडल डाल के स्पर्म्स निकालने। नॉन ऑब्स्ट्रक्टिव में दो तरह की पिक्चर आती है। एक तो बिल्कुल जो स्पर्म जो टेस्टिस है वो बिल्कुल बटन जैसी हो जाती है। इसमें भी हम कहते हैं कि इसमें कुछ नहीं निकलेगा, एफएसएच नॉर्मल है एंड इसका एंड ऑर्गन फेलियर हो गया। बट आज की साइंस ये कहती है कि इसमें भी बिफोर यू से नथिंग कैन बी डन, यू शुड सेंड देम टू urologists who are trained in microsurgery and who can, okay, they may be charging lakhs and lakhs of rupees, but they can get you the sperms. But जो ये वाले हैं testes, which is either normal or slightly less than normal. Now in cases के अंदर almost 80% में the sperms can be retrieved. So आपने देखना है कि कहाँ पर प्रॉब्लम है, वास में है, एपिडिडिमिस में, टेस्टिस में, साइज देखना पड़ेगा, सीमन की वॉल्यूम कितना है, पीएच कितना है, फ्रक्टोज कितना है, और उसका पेशेंट का एफएसएच लेवल और एंड्रोजन लेवल कैसे है। तो वही मैंने बताया था आपको, यहाँ पे कोई स्पर्म्स नहीं है, यहाँ पर ये ऑब्स्ट्रक्टिव में पूरे स्पर्म से भरा पड़ा है, और जो साइज ऑलमोस्ट नॉर्मल है, स्लाइटली कम देन नॉर्मल है, इसमें पैचेस स्पर्मेटोसिस देती है, और इसमें ऑलमोस्ट 80% में an ordinary IVF center should be able to take out the sperms. Now, testicular biopsy should be done in a center where the semen freezing facility is available. आपने बायोप्सी की, आपको स्पर्म्स दिखाई दिए, उसको चाहे 5 है, 6 है, 10 है, स्पर्म्स को उसी टाइम फ्रीज करना लेना चाहिए, जिससे कि वो IVF इक्सी में यूज हो सके। So doing biopsy in a setting which is not an IVF center where the freezing facility is not done is crime. You should not do it. Isolated foci of sperm production can be used in TISA and ICSI, and that is why even single sperm should not be wasted. Now, जिनको low sperm count है, कहते हैं कि लो स्पर्म काउंट का मतलब है 5 मिलियन से आपका काउंट कम है, एंड इट इज अ नॉन ऑब्स्ट्रक्टिव एजोस्पर्मिया। इनमें आपको जेनेटिक स्टडी भी करनी चाहिए, इसमें आपको हार्मोनल स्टडी करने। जेनेटिक स्टडीज में 3 चीजें इंपॉर्टेंट है। एक तो होता है आपकी क्रोमोसोमल एनालिसिस, कि नंबर कितना है क्रोमोसोम्स का, 46XY है कि 47XXY है। एक तो ये, एक इनकी वाई क्रोमोसोम के अंदर छोटा सा पार्ट वाई क्रोमोसोम्स का डिलीट हो जाता है, उसको बोलते हैं माइक्रो डिलीशन ऑफ वाई क्रोमोसोम। एक ये टेस्ट करना है, और एक हम लोगों को आपको CFTR जो टेस्टिंग सिस्टिक फाइब्रोसिस की जीन का टेस्ट करना पड़ता है, बोथ हस्बैंड एंड वाइफ में। देन हमको पता करना है कि कोई इंपेरिकल मेडिकल थेरेपी तो नहीं ली है इस पेशेंट ने, और वेरिकोस सर्जरी इज नॉट ऑलवेज हेल्पफुल, वन हैज टू बी वेरी वेरी केयरफुल। आई एम गिविंग जस्ट एन ओवरव्यू। हमारे कई जब पेशेंट को एजोस्पर्मिया आता है, हम बोलते हैं कि पेशेंट को यूरोलॉजिस्ट के पास भेजो. But it is a knee-jerk response should be avoided. Referring to the urologist does not do any purpose. Patient को क्या चाहिए? Patient को बच्चा चाहिए. And the urologist failed to deliver it even in a male infertility. जो infertility expert है उसको ही पास भेजना चाहिए. That person should be able to give you the child because of the assisted reproductive techniques. Now, for all of you, simple rule hai, IUI should be done only if the count is more than 15 million. Ye 20 million purana hai. If it is more than 15 million, then the IUI should be done. In no case IUI should be done if the count is less than 10 million. If the total motile sperm count, is less than 10 million, the patient must be offered IVF. If the total motile sperm count is less than 5 million, then the couple should be offered ICSI. Is it clear? IUI, if it is more than 15, in no way it is less than 10 million से करना ही नहीं चाहिए IUI. 10 million से कम आपको IVF करना है, 5 million से कम आपको ICSI करना है. IUI is not a sensible treatment for a low sperm count. Secondly, washing should be done for IUI should be done in-house. It should be done in-house, which is not being done for most of the people who are doing IUI. Dilemma with low sperm count is counseling happening, low sperm count hai, इससे परेशान होने की जरूरत नहीं. We need to investigate them, and IVF ICSI is the definitive modality which can give children to all these patients with male infertility. The common mistake which we gynecologists do is, because who are not trained in infertility, are giving repeatedly clomiphene again and again. And we know that after 6 cycles, there is a chance of ovarian cancer definitely increases in patients where we just keep on giving. This endometriosis I will talk in detail. I am not going to really bother you at this time. Tubal infertility में जब भी आपकी tube blocked है, always think of tuberculosis before advising them for IVF. Hydrosalpinx, if it is there, it has to be removed. Now there is no controversy here that hydrosalpinx, if there, they have to be removed. Then cornwall block के लिए पहले हम लोग ट्यूबोप्लास्टी करते थे and cornwall resection करके surgery करते थे. But अब कहते हैं cornwall block करने की जरूरत नहीं. These people should be asked hysteroscopic tubal recanalization डालना चाहिए. और उनके हिसाब से खाली थोड़ा सा कई बार adhesions होते हैं, वो इस cannulation से, which is done hysteroscopically, can open the tube, and in case if it is not, then the patient should be offered IVF instead of getting tuboplasty done. The tuboplasty is almost disappeared now. We'll talk about PCOD in detail according to the Rotterdam criteria, and I'm not going to waste time here. It is just overview. But in PCOD, we have seen is that anybody who's obese, 5 kg loss can do the trick. 5 kg loss can do to the trick. Pediatric surgery now, both the ASHRAE, as well as the WHO says that pediatric surgery should be resolved early in infertility than late, both for male and the female, because the over-obese people, the morbidly obese patients cannot conceive, and in case if you do pediatric surgery, then they readily conceive in majority. And our experience also shows out of the 32 cases where the pediatric surgery was done, 23 already have pregnancy. Pediatric surgery in younger people, this is the kind of surgery is done in such cases, and this is called sleeve gastrectomy. This bypass is done for older malabsorption patients. This is not done. This is the technique which is done. And this particular slide is very dear to me. This shows that weight loss patients are queuing up in front for pediatric surgery, and once they get pediatric surgery, they come out with pregnancy. And quite a few have their pregnancy on their own, where the IVF had failed earlier. ART are what is called assisted reproductive technology. They are simple procedures, but they increase the chance of the eggs and the sperm meeting. And what is not happening in the bedroom, we do it in the lab. So IVF को एक lab वाली बात नहीं करना चाहिए. Here, your natural things are combined with the lab facilities, and you get the baby. And there is nothing artificial. We just assist nature. There's no increased risk of birth defects has been noted in IVF babies. IVF, some people say the IVF is too expensive. Maybe, but just because the right treatment is expensive does not mean that you keep on doing the wrong treatment just because it is cheap. And often IVF is more cost effective than going and changing the doctor from here to there. So the rule is, how do you make out which is a good clinic or bad clinic? Doctor communities are in a bad habit of taking commissions, and there are few IVF centers, not only few, many IVF centers give cuts of almost 50%. Unfortunately, for doctors, good clinic is where the highest cut is there. And I think this particular practice should be given up. People talk about what is success rate. For a patient, success rate can be 0% or it can be 100%. जिसको pregnancy हो गया उसके लिए 100% और जिसको pregnancy नहीं हो उसके पास 0%. पर मोटा मोटा आप लोगों को पता होना चाहिए. Anybody who's going for IVF cycle और उसका अपने अंडे, तो there is a success rate is 30 to 40%. And if it is donor cycle, the success rate is not more than 50 to 60%. And it's good to give all IVF centers, it is good to give the picture of the embryos which you have transferred. Because the picture seen by you, one picture speaks 1,000 words. आपने जो picture दी है वो अपने relatives को दूर दराज वर्ड में भेज सकता है, पता कर सकता है कौन सी क्वालिटी के अंडे डाले गए थे. Now, factors affecting pregnancy is the IVF lab. सारा जो success का राज है वो IVF lab में है. There are 4 key areas to improve the outcome in IVF. Diagnostic evaluation बढ़िया करें, improve the health of the sperms, improve the fertilization technique, and improve the sperm retrieval procedure in cases of where you have azoospermia. It is good thing which has happened is that if I don't have sperms, the donor sperms can be taken. If I don't have the eggs, the donor eggs can be taken. So the third party reproduction has made a real difference. If my uterus is not good, I can take the surrogate uterus. If my eggs are not there, I can take donor eggs. And if I do not have sperms, I can have that. If both have problems, they can have a donor adoption. Now, ART की जो success story क्या है? एक हमारे को जो super ovulation की technique को हमने perfect कर लिया है. So we have multiple eggs. And the multiple eggs are that हम लोग 10 अंडे बनाने की कोशिश करते हैं जिससे हमें 1 या 2 blastocysts मिल जाए. Egg collection should be perfect. लैब में in vitro में incubators के अंदर इनको fertilize करते हैं and फिर embryo transfer करते हैं. This is what it is, that you are retrieving the eggs. इसलिए यहाँ पर जो भी इनफर्टिलिटी एक्सपर्ट बनना चाहते हैं उनको ट्रांसवेजान सोनोग्राफी में परफेक्ट होना पड़ेगा और उसको बहुत मुश्किल नहीं है बिल्कुल सीखना. At our place, 5 days we do online class and 3-4 days we want you to be here so you can have hands on and आप अपने आप ये कर सको कि इस प्रोब से यहाँ मुझे यूट्रस दिख रहा है, ये मुझे ओवरी दिख रही हैं और मेरा ये इंटरप्रिटेशन है. Now, in vitro में जो है about a lakh sperms retrieved egg के चारों तरफ वेल में डाल दिए जाते हैं, washed sperms, and it is put into CO2 incubator at 37 degrees centigrade and their fertilization takes place. While ICSI is the biggest breakthrough, where one egg by machine, by the ICSI machine, one sperm is put inside one egg only. This technique will be demonstrated to you in very beautifully. The blastocyst transfer is, that is day 5 embryo. If you transfer, it has got a 50% success, not 100%, 50% success. The number of embryos which reached day 5 are very few. So your lab has to have a maturity to culture to the blastocyst stage. On day 3, if you're finding 4 or 5 eggs, it is only possible that 1 or 2 blastocysts may be formed. Now, the real problem is our paperwork in our country. And I think, that has to be, they are very, very strict about this. Something has to be done at this end. IVF is the biggest gamble and no one can predict results. I've been in the IVF game for a very long time. It is almost, I should say 13 years. And I can say that when you say that the pregnancy will occur 100%, the pregnancy will not be there. When you are sure 100% pregnancy will not be there, the pregnancy is there. So that's the story about thing. The freezing, this cryopreservation, which is called vitrification, has changed dramatically. Now with the vitrification is fast freezing. This can be done for your sperms. This is now done for your embryos. This is done for eggs. This is done for ovarian tissue. This is done for testicular tissue. The government guidelines are that once the law will be there, surrogacy law is there now, cleared by the parliament. You have to follow strictly that. If you fall out of the line, you can have a lot of litigations. The similar way, as far as the ART thing is concerned, it is still not clear, and still the guidelines. And once it is cleared by the parliament, then only they will become the real law. In real life, the bureaucrats only understand the paperwork, so you find paperwork is there. Good doctors do not need to be monitored.